completed her training at Vanderbilt University and, completed her MD PhD at Vanderbilt University, and her training in pediatric neurology and movement disorders here at WashU and St. Louis Children's Hospital. She spent 3.5 years at the University of California, San Francisco, establishing a joint pediatric movement disorder program between UCSF and Children's Hospital in Oakland, where she completed a small clinical trial of deep brain stimulation for cerebral palsy before returning here to St. Louis last year. She was a co-author on the first publication detailing the movements into GNAO1 that can cause epilepsy and movements. And Dr. Goodkin, just while you're getting set up.
Yeah.
Go ahead. Dr. Goodkin has recently been appointed the chair of neurology at the University of Virginia, and he's here with us today, and he also serves on the Broad Foundation Scientific Advisory Committee alongside Amy. He's the Schur Professor of Neurology and Pediatrics. He's a nationally recognized clinician, educator, and scientist, and he received his BSc and MSc in biomedical engineering from the University of Pennsylvania. He got his PhD from the Medical Scientist Training Program here at WashU in St. Louis, and his pediatric residency training was at St. Louis Children's Hospital, where he also performed pediatric neurology and epilepsy training at Boston's Children's Hospital. So that's a long way of saying we have some great experts. I want to give you a sense for who you're hearing from before you hear from them. So y'all will take about 30 minutes and just walk us through what is GNAO1.
So hello, and thank you so much to everybody who has traveled so far, or even not traveled so far, to be here with us. It really is, a labor of love putting this all together, seeing all of your wonderful faces, seeing all of your children's smiles has just really made it totally worth it. So for those of you that heard us speak in DC in 2017, some of this will be a little bit of a repeat. I'm going to talk about the movement aspects of GNAO mainly, and Dr. Goodkin is going to address more of the epilepsy part. And I'm going to try and give you a little bit of an update of what we know differently from what we knew before, so that everybody's on the same page. So a lot of people ask me, well, how did you kind of become an expert in GNAO1? And it really started with a little girl named Lara. She was born after a normal pregnancy and delivery. She was noted early on, like many of the kids here, to be hypotonic around 6 months of age, and she wasn't meeting her milestones. She had a huge workup at the time, lots and lots of tests, and nothing came back positive. I'm sure this is sounding very familiar to many of these families. And then she started developing chorea about age 4. And this was pretty stable. She was making good developmental progress. She was learning how to use a head switch to communicate. She was going to school. And then around age 8, these movements started to get more serious. And so this is, a lot of you probably have been in this situation, so a decision was made to do some video EEG monitoring just to make sure that these were seizures, even though they didn't really look like seizures. And so this is probably from when she was about, I'd say 6, I don't know. And you can see this kind of, so this is chorea. It's a very jerky type of chorea, and it's it's there. It's not really bothering her until some of this starts, and then she starts flailing and she has no control, and then she rests a little bit. Unfortunately, some of these more kind of flailing movements that are kind of more ballistic, like this, around age 8 or 9, became continuous. To the point that she would go on for days and weeks at a time with no break. It was so bad at one point that she was cutting off her airway, and we had to put a tracheostomy tube in. And she was in and out of the ICU for about 18 months before she unfortunately passed away at home. We got the whole exome results back while she was in the hospital, and the initial report said that this gene mutation was not likely to be causing this child's symptoms because she did not have epilepsy. But I took a look at the paper that was published. There had only been one paper at that point from the group in Japan, and I took a look at the patients, and I said, this is what she has. And I stole these figures from Dr. Newbig's excellent work in his paper. The GNAO1 encodes the alpha subunit of a nucleotide binding protein called GAO. It's a very abundant protein in the central nervous system. Approximately 1% of the total brain membrane protein. It's expressed ubiquitously, which means it's expressed everywhere. But it's especially high expression in the hippocampus, striatum, and cerebellum, which makes a lot of sense, being that the hippocampus is very important in epilepsy, and the striatum and the cerebellum are very important in controlling unwanted movements. And it's involved in the processing of different neurotransmitters and regulating how the different neurons communicate to each other. And I won't go into this. I'll let Dr. Newbig go on to this. So what does that mean in our patients? So almost all of our patients initially present with hypotonia and developmental delay. The story I heard over and over again the last couple days was we started noticing around 6 months of age that they weren't meeting their milestones, and that's when we became concerned. Despite this, and many of the children don't have the ability to talk, I'm firmly convinced that the vast majority of these kids have preserved intellect. So usually it's characterized by either early epileptic encephalopathy or a movement disorder that can be a mixed movement disorder of dystonia and chorea, but has these episodes of chorea, or both. Okay, there is an emerging what we call genotype-phenotype correlation, which means that the where the mutation is seems like it might correlate with what symptoms the patient is developing, and we think that it looks like a gain of function of the protein might produce the movement disorder, and a loss of function might produce the epilepsy, although this is still unclear and not conclusive. But what's unique to this disorder and kind of distinguishes it from other disorders where we have a combination of epilepsy and movement disorder, which there are many, is these chorea storms that land kids into the ICU. And it's really, the bolismus is this flinging movements. And then it's also, these flinging movements are so dramatic they cause breakdown of muscle tissue, which it's called rhabdomyolysis, and can cause lots of problems, including kidney failure. And this autonomic instability that I think we are also seeing at lower levels in many of our kids, where they have difficulty regulating their temperature, they get spikes in heart rate and blood pressure, and these can be associated with movements, but can also occur in the absence of the movements. So I'm not going to go too much into this slide, but this is Dr. Newbig's most recent work at looking at 50 cases that he's collected, and you can see that that there's movement disorder only in 20, both epilepsy only in 12, and both in 18. So a wide variety. And it was first described as only being in girls, but clearly it's nearly equally present in girls and boys. So to talk a little bit about the movements. So whereas I used my initial patients all had pretty much movements, limited as chorea. As I've seen more and more patients, it becomes clear to me that the spectrum of the movement disorder is really quite diverse. I would say the majority of the patients that I saw over the last 2 days had a mixture of dystonia and chorea. Most had some element of hypotonia. There were a few that had some spasticity, but dystonia and chorea were the kind of two most common. Dystonia tends to be action-induced, and we're going to see some videos of this. And the chorea tends to be more a little bit at baseline but can get more severe, more episodic. Tone is a little bit different, and so tone is something that you have to feel to diagnose. So you can't diagnose spasticity by looking at somebody. You have to feel it. And although you can see the manifestations of hypotonia or spasticity with the head drops and the tightness of the legs and the arms. So the dystonia is, to make sure everybody's on the same page, is sustained intermittent involuntary muscle contractions that causes abnormal movements, repetitive movements, postures, or both. So this is one of my patients who does not have GNAO1, but she has a genetic dystonia associated with deafness, and she's trying to sign here, and she's bracing her arm because it wants to twist and hit her head. And you can see her trunk is twisting, and she can't maintain her position. But dystonia typically gets worse with action. But can be present at rest. Chorea, on the other hand, is kind of these more ongoing, random, kind of dance-like involuntary movements that can evolve into the more violent flinging that we saw. This is from the initial Japanese paper, and you can see that the postures are not sustained. They're kind of fluid. They seem to be random. At lower levels, it can seem like the kid's just restless or they can't sit still. Sometimes kids will get in trouble because of this at school. And it can be important and because they do respond to different treatments. And when you see them in a mixed picture, as is with our kids, it can be challenging to treat. So how do we treat this? Well, I usually like to think of treating movement disorders in categories. So we have medications, we have surgery, we have therapy, and we have Botox. Medications and therapy are usually where we start. So for the acute exacerbations of the movements, benzodiazepines and neuroleptics are probably the most effective. These are not ideal medications that continue in the long term because they all have significant side effects, including cognitive side effects. For more long-term management, most of the time I like tetrabenazine. That has seemed to be most consistently what seems to work, especially for the chorea, with minimal side effects, although some kids do have many side effects with this medication, and it seems to not be consistent as far as from patient to patient who's going to develop side effects and who's not. There's been some sporadic reports of topiramate and clonidine. These have not been replicated, and I have not seen any success with these medications. Botox can be very effective for the spasticity and for the dystonia. And then we get to deep brain stimulation, which I know many of the families have lots of questions about. So deep brain stimulation was developed initially for Parkinson's disease and essential tremor. And it's where we put an electrode down to the deep parts of the brain that are important for modulating movement. So telling the brain, oh, you're moving too much, oh, you're moving too little. And then we connect that electrode down on a wire that goes tunneled underneath the skin, that goes behind the ear to a generator that has an implantable battery that we can access magnetically or non-invasively to adjust the settings. And what we think is that the generator delivers electricity that either overrides or modulates the abnormal signals that are coming from those deep structures of the brain, although it's the exact mechanisms are not completely understood and is a source of active research both here and elsewhere. In these extreme cases, even though this is not approved for GNAO1, many clinicians have looked to deep brain stimulation to see if we could get rid of these abnormal movements and keep the kids out of the ICU. And so the most recent evidence for efficacy was in a paper by Anne Coy, who's in Germany, where she published 6 new cases from Germany and France, and reviewed the literature and reviewed 6 other published cases. And for all 6 patients, there's a new missense mutation that she reports and a new splice site mutation that she reports. All patients, she describes in the paper that 5 patients responded. I since have communication from her that it looks like the 6th patient is also doing better, but it's really early on in programming. She recommends that DBS be considered as first-line therapy, which is somewhat dramatic to suggest that a brain surgery be considered first-line therapy. But many of us that treat these movements are coming around to consider this as first line as well. Historically, you've had to prove that patients have failed many medications before you can consider something like this. However, there's a caveat that's buried in the paper that they don't really advertise. But one of the patients did have several lead fractures requiring multiple revisions of the DBS. And during one of these periods of time where the DBS was not active, the movements came back and the patient died. So, while we have great hope for deep brain stimulation, and as I've talked to many of you before, it has to be weighed with the potential side effects and complications of undergoing, a brain surgery, and especially in heads and brains that are moving a lot, and the increased risk of lead fractures and infections that we see in children. But so I will show you some videos because I'm movement disorders, and we can't do a presentation without videos. Although, how do I get? Okay, hold on. I'm just gonna go to the actual paper because it's easier to kind of scroll through the videos. So this is a patient who has been implanted for 10 years, and they claim that this is the longest active patient with deep brain stimulation for GNAO1 ever published, which we know there's one here today that's been published that has had DBS for longer, so maybe we should publish that. So this is early on. I think the patient was 11 years old. And you can see kind of an unsteady, they call it ataxic gait. There's some dystonia there that's preventing the kind of fluid movement of the legs. And you can see the kind of hypotonia, the decreased muscle tone having to be held up. Play it one more time. There's probably a little bit of spasticity there too, although I can't tell without examining the patient. This progressed at age 13. The patient was obviously in the ICU with these just kind of constant movements and developed rhabdomyolysis, which is the breakdown of the muscles. And you can see some of it in the face as well. Okay, and this is after DBS. So, one of the things that has become very obvious is that we can get rid of the abnormal movements with DBS. We can't get rid of the hypotonia. This is 9-year follow-up. And then this is when she had the DBS turned off so they could do an EEG. And you can see that so right now what you're seeing is kind of more dystonia. You're seeing the kind of flexed postures, the fixed postures, the twisting, and then a little bit of chorea, but mainly what I'm seeing is kind of some more dystonia.